We're talking here about a 69-year-old male with advanced CSCC. This patient had fair skin, generally healthy, retired from construction work where he had a lot of ultraviolet exposure. He was well until he noticed a tender spot behind his ear, which grew. This was biopsied and found to be a poorly differentiated SCC. On clinical examination, the patient was found to have a 4.5 centimeter diameter lesion with erosion that was greater than 5 millimeters. The pathology showed a poorly differentiated squamous cell carcinoma, a cutaneous squamous cell carcinoma, with a depth of 7 millimeters. The patient was recommended to have a partial auriculectomy and radiation. The patient declined. He was started on cemiplimab 3 mg per kg per day every 2 weeks. So there wasn't perineural disease noted on the biopsy, but in this area you have to wonder if there's a facial nerve extension through the stylomastoid foramen, whether there's any anterior grade perineural disease, and for that reason you would consider using MRI to detect perineural extent. If you believe that the biopsy didn't show perineural and you don't need to check for that, a CT would be a faster study that many patients can tolerate better with less artifact. You can consider doing scouting biopsies, multiple additional biopsies. Since it's such a large lesion, one single biopsy is subject to sampling error. So even though there wasn't perineural disease found in that one sample, if you did scouting biopsies throughout the lesion, you might find that, and that would be very helpful to know up front so that you could pick the best imaging modality. My initial impressions of this case is that you have a tumor that is large in diameter, quite deep. So the risk factors include diameter, depth, poor differentiation. Anything around the ear is a multiple tissue plane, so a high-risk area for deep extension. Often potential extent through cranial foramen, such as stylomastoid foramen. So very high-risk disease. The ability to remove this surgically could be temporal bone resection, complete loss of hearing on that side, disfigurement in terms of loss of most or all of an ear. And with those considerations, it's reasonable to think of other options, so a systemic therapy. The systemic therapy category I would think of would be an anti-PD-1 agent. And we could consider cemiplimab as an option.